A very good evening to all the participants who have joined for the National Clinical Meet series, which is being planned every month from different state chapters. For this month of October, we are proud to have FPI Kerala chapter hosting the National Clinical Meet series for this month. In fact, this is the first clinical meet series after the installation of the new national executive, and we have National President Colonel Dr.On Kubendra sir joining for the event, as well as National Secretary Dr. Rashmi ma'am has joined, as well as the former Dean Dr. Srinivas sir. All have joined for the event. Welcome you all for the National Clinical Meet series for the month of October. So the topic we have chosen for today is one very relevant clinically important topics, as well as for the postgraduates. It's a very important topic for the exam perspective. That is the pregnancy and thyroid disorders. What are the updates in the management? To give the deliberation on this topic, we have one of the senior most faculties in family medicine fraternity, Dr. Indu Rajiv. She is a senior consultant in family medicine and working at Luce Hospital, Kochi. She's also the president of AFPI Kerala chapter. Over to Indu ma'am for your deliberation. Thank you.
Yeah, good evening all. And thank you, Dr. Vishnu, for the nice introduction. And good evening, all my dear colleagues, and Dr. Kubendra, Dr. Rashmi, and congratulations to all the national executives also. I'm sorry, I have a very bad throat after my Rishikesh trip. So I have to take some effort to put out some sound. I hope you all bear with me. And today's topic is pregnancy and thyroid disorders and the updates in management. Now, why thyroid disorders in pregnancy is important? You all know that pregnancy is a very delicate situation, and it is necessary for each of us to be aware of the various factors that can prevent a healthy pregnancy. And thyroid awareness in pregnancy can be a lifesaver. If every family physician or every doctor is aware of this thyroid and the problems regarding that, it will be a lifesaver for the mother and the baby also. And you all know that thyroid hormone plays an important role during the development, fetal development, the neurological development, and also the continuation of pregnancy. Now, coming to the thyroid disorders in pregnancy, there's a physiological issues. Hypothyroid, which could be overt, subclinical, or postpartum. Hyperthyroid could be Graves' disease, again subclinical, gestational thyrotoxicosis, and postpartum hyperthyroid, thyroiditis. The other group which is seen in pregnancy is thyroid nodules, which could be a benign one or a malignant one, and you need to understand when to intervene these problems in pregnancy. Other common thing is postpartum thyroiditis. We'll deal with each and everything. Now, coming to the pregnancy hormones in pregnancy, we all know that the common hormones which are increased in pregnancy are estrogen and the human chorionic gonadotropin. And increased estrogen, what happens when there is increased estrogen? There is an increased production and a reduced clearance of thyroid binding globulin, which leads to increase in total T4 and T3. And usually the total T4 range is 1.5 into the normal non-pregnant range. Similarly, HCG, since it bears a similar structure that of TSH, what happens is it has got thyrotropic effects. And the first trimester, what happens, increase HCG leads to decreased thyroid stimulating hormone. So initially there is a transient decrease in the TSH in the early weeks, 8 to 14 weeks. And HCG stimulates the release of T3 and T4. It leads to the gestational thyrotoxicosis, which is very common and need not be treated. Usually subsides by the second trimester of pregnancy. There's an increased peripheral metabolism of thyroid hormone, which leads to the decrease in the unbound, that is free T3 and T4. And there's also a demand of T3 and T4. Other variations are increased plasma volume, leading to dilutional problems. And one more fetal consideration is there's a non-functional fetal thyroid until 10 to 12 weeks of pregnancy. That's why the mother has to be supplemented enough of thyroid hormone to protect the baby's neurocognitive development. So this is a chart showing how estrogen and HCG affect on the thyroid hormone. Now here you see increased estrogen leads to increased thyroid binding globulin and a decreased clearance. So this thyroid binding globulin, it's a protein which carries total, that's the total T4, total thyroxine. So total thyroxine and TBG are on the higher side in the early pregnancy and throughout the pregnancy. At the same time, the free T4 levels are on the lower side. Similarly, since there is increased HCG, there is a decrease in TSH, and then later on by the third trimester, TSH reaches to the normal state. So there are different stages in the first, second, and third trimester. There are a lot of variations in the levels of T4, TSH, and FT4, and you should know what test you need to do during the pregnancy. Like T4 is preferred during pregnancy. Initially, it was thought that free T4 is best for the controlling the thyroid levels in pregnancy, but now it has changed. Now total T4 is more recommended test in pregnancy along with TSH. Now coming to what are the things that transfer across the placenta. Now iodine, you know, it's an important element for the synthesis of thyroid hormone. So the mother has to be supplemented with iodine. You know, the commonest cause of hypothyroidism is the two causes, Hashimoto's thyroiditis, other one is iodine deficiency. And iodine has to be supplemented enough to the mother. And according to the recommended dietary allowance is around 220 to 290 micrograms. And if you had to give a supplement of iodine, just to be given at least 150 micrograms per day in pregnancy, because iodine is transferred avidly across the placenta, the passive and active transport. Thyroxine also is transferred seen in the first trimester. TSH is poorly transferred. Similarly, antibodies, they can cause the placenta freely. The TPO antibodies, thyroglobulin, thyroid stimulating immunoglobulins, all can cause the placenta freely, causing neonatal hyper and hypothyroidism. Coming to fetal considerations and maternal considerations, it is seen T3's presence is seen in the fetal brain at 7 weeks of gestation. And you all know fetal thyroid tissue develops at around 11 to 12 weeks. And that's why the mother has to be supplemented by enough thyroxine so that till the fetal thyroid develops. The hypothalamus pituitary axis starts functioning at 20 weeks, and placenta is permeable to T4, iodine, and thyroid stimulating antibodies, and also the anti-thyroid drugs. Now, any patient seeking pregnancy, what all should be done? So, any patient seeking pregnancy, newly pregnant, should undergo a clinical evaluation. According to the ATA guidelines, if any of the following risk factors are identified, testing for TSH is recommended. And these are the conditions where TSH is recommended, where there is history of hyperthyroidism, or with symptoms and signs of thyroid dysfunction, TPO antibody positive, presence of a goiter, any head and neck radiation or prior thyroid surgery, age more than 30 years, type 1 diabetes or other autoimmune disorders, history of pregnancy loss, preterm delivery, infertility, multiple prior pregnancies, family history, morbid obesity, use of drugs like amiodarone lithium, or a recent administration of iodinated radiologic contrast, residing in an area of a moderate to severe iodine deficiency. So these are all patients as testing for serum TSH is recommended. Now, there are certain studies comparing universal versus selected case-based screening, and meta-analysis has shown that case-based screening can miss up to at least 49% of the pregnant women with thyroid dysfunction. So any patient presenting to you with an early pregnancy, kindly do the screening test. That is simple TSH is enough. So according to in the ATA, around 140 members had voted for this. In 140 members, the members of the ATA, and the screening and treatment of hypothyroidism of pregnancy, out of which 100%, 70% advocated for universal screening. Only 18% were against universal screening. All problems because of the government support in other countries, because the government needs to support all this tests. In India, actually, it is only the patient who is paying for all this. So I think better, according even to the Indian thyroid guidelines, more than 70% have advocated for universal screening. So according to the ATA itself, around 70% advocated for universal screening. Now coming to Indian Thyroid Guidelines and the FOGSI. FOGSI is a Federation of Obstetrics and Gynecological Society of India, 2019. One of the latest also has come in 2021. So the recommendations are all pregnant females should be screened at the first antenatal visit by measuring the TSH levels. That is a 2A and B recommendation. Now, how frequently to monitor and who should be monitored? So women who should be monitored, women with overt or subclinical hypothyroidism, either treated or untreated, or the risk of hypothyroidism, that is patients who are euthyroid but thyroid antibody positive or thyroid globulin antibody positive, post-hemithyroidectomy or treated with radioactive iodine should be monitored for TSH. And how frequently you need to monitor? Every week till the mid-gestation, and in the third trimester, at least near the week 30, around the 28 to 38 weeks, you need to have the second test. After starting treatment, kindly check every 4 weeks till the mid-gestation. It's very important. Now, coming to the guidelines, recommendation for the upper TSH limit during pregnancy. The Indian Thyroid Society is a very easy one, and the European Thyroid Guidelines also. Both are similar. And ATA guidelines, they have gone slightly for the upper reference range of TSH around 4. But I think it is easy to follow the Indian Thyroid Guidelines. The trimester-specific TSH, that is the first target at least. The upper reference range is 2.5. In the second and third, it is 3. Now, whether to test a total T4 versus free T4, I told you there are a lot of proteins in the early, that is thyroid binding globulin and the non-esterified fatty acids, and a decrease in albumin also can affect the FT4 concentration. If needed to be tested, the test to be assessed by equilibrium and dialysis or ultrafiltration, and which is more reliable than automated immunoassays. Since it is expensive and not commonly available, they have recommended the testing of total T4 instead of free T4. That in the early pregnancy. Late pregnancies of FT4 is slightly on the higher side, but early pregnancy at first and second trimester, the FT4 is on the lower side because most of the thyroxine is bound to the protein. Now, following conception, thyroid binding globulin and TT4 concentration increased by 7 weeks of gestation and reach a peak by approximately the week 16. So up to weeks 7, TT4 is usually recommendation is you can use the pre-pregnancy range up to week 7, and week 7 to 16 upper reference range by 5% per week, and from week 16 onwards upper reference ranges by increase the range by 50%. So the TT4 is usually checked in hyperthyroidism. In hypothyroidism, usually you go along with the TSH only. So TT4 is only for mainly for hyperthyroid patients. So they come to a conclusion that according to the ATA, TT4 measurements may be superior with a pregnancy adjusted reference range to immunoassay measurement of FT4 measurements in pregnant women, especially during the last part of, and FT4 is only done during the last part of pregnancy, as I told you earlier. TT4 is during the first and second trimester of pregnancy. And accurate estimation of FT4 can be done by the FT4 index. That's the T4 by the thyroid uptake also, which can be, you can evaluate the FT4 index instead of FT4 alone. Now coming to the case. So all the answers will be coming in the further slides. So this is for the PGs. So if a 26-year-old female married since 1 year is planning a pregnancy, a routine TFT shows a TSH of 4 international units per liter, and FT3, FT4 is normal. So what is the diagnosis here? So anything between 4 and 10 is subclinical hypothyroidism. Whether to treat or not in a patient planning a pregnancy is still a question. But I think it is, if you go for a thyroid peroxidase TPO antibody and find out if the patient is, the female is positive, and if the target should be between 2.5 and 4 when the patient is diagnosed to be pregnant. Okay, so you need to advise the patient. As soon as the patient, just check the TPO antibody positive and keep. As soon as the patient comes for the first visit, first antenatal visit, again go for the TSH. And if it's between 2.5 and 4, just treat the patient with a small dose of thyroxine, and monitoring, as I told you, should be every 4 weeks till mid-gestation. So this is a case of subclinical hypothyroid female who is planning a pregnancy. So you need to monitor this patient, and you have to tell that as the patient has to present as soon as the patient is diagnosed to be pregnant. Okay. So it's a case of subclinical hypothyroidism. Now this is a 30-year-old female taking 25 microgram of thyroxine since 5 years. The family history of hypothyroidism. The TSH values are again 2 millions per liter. Married since 2 years, again planning a pregnancy. What is your advice? So this all type of patients can come to your OP. And again, it's slight confusing because TSH values are 2.5. She's only planning a pregnancy and she's got a pre-existing hypothyroidism. So take a short clinical history and a family history also, look for goiter, etc. And by previous TSH values also has to be noted whether this female was a overt. Overt means TSH values more than 10 with the T4 values, a normal FT4 or total T4 values. So in this person, what will you advise? What will be your advice? Again, you can check on the thyroid peroxidase antibody. It is very important because there's a family history of hypothyroidism. Okay, so there could be a chance of Hashimoto's thyroiditis. And TSH value 2.5 is acceptable. And as soon as a person becomes pregnant, you need to target the value less than 2.5. So what we say is, as soon as a person becomes pregnant, you increase 30% of the pre-pregnant dose. That is, you add 2 more doses per week. That is, you add again to 25 plus 25, 50 microgram of thyroxine per week and monitor every 4 weeks. So this is a 26-year-old female in early pregnancy. That is, she's in 4 weeks. Refer to you with a TSH of 12 international units per liter. FT4 is 0.9. This is slightly on the lower side. Now, what will be the diagnosis here? So this is a case of overt hypothyroidism. Overt hypothyroidism, the treatment is immediately start thyroxine in the dose of 1.6 to 2 microgram per kg. That is around 100 microgram of kg has to be 100 microgram has to be per day has to be advised. It has to be taken immediately. So you need to give an advice, start the treatment immediately. And TPO, or by the way, you need to check a TPO for the cause of hypothyroidism. You need to check a TPO and all. But immediately start off thyroxine at the dose of 1.6 to 2 microgram per kg, around 100 microgram per day. And check again, monitor every 4 weeks and target a TSH in the first trimester less than 2.5, second and third trimester less than 3. Now, this is a 30-year-old female, immediate postpartum, was on 50 microgram of thyroxine, started in a pregnancy with no pre-existing hypothyroidism and TPO antibodies negative. And what is your advice? So this person has delivered. It's an immediate postpartum. She was not on any thyroxine before pregnancy, and 50 microgram was started in her pregnancy. So according to guidelines, anything less than 50 can be stopped if the patient was not taking any thyroid medication before her pregnancy. And it's TPO antibody positive. The only thing you have to do is check after 6 weeks and target between 4 and 10. Postpartum, 4 and 10 is okay. And TPO, suppose the TPO is positive, the patient needs regular monitoring annually. And before planning a second pregnancy also, this patient has to be advised to monitor the TSH, and a pre-pregnancy planning also has to be given. This is the duty of the family physician here. And everything has to be, so any hypothyroid has to be informed to the gynecologic obstetrician, and the management part also has to be explained to the patient and the obstetrician too. Because these patients will be discharged on or stopped on thyroxine, because if they are not aware of that, the patient may not take medicine and may not come for a checkup also. So coming to the hypothyroidism in pregnancy, now coming to the incidence, 0.2% are overt, 2 to 7 could be subclinical, and thyroid antibodies could be present in around 60% of the patients. So coming to the definition of overt, it's elevated TSH more than 10 with a decreased free T4 concentration outside the trimester specific ranges. In subclinical, serum TSH is between 4 and 10 with normal T4 levels. And what are the causes? Hashimoto's, commonest cause, radioiodine ablation, thyroid surgery, iodine deficiency. The central hypothyroidism is another group which has to be evaluated separately, and drugs causing. There are certain drugs which can cause hypothyroidism like this, amiodarone, etc., lithium, etc. And what are the complications of untreated hypothyroidism in pregnancy? Maternal could lead to anemia, congestive heart failure, preeclampsia, placental abnormalities, low birth weight, postpartum hemorrhage myopathy, fetal cognitive impairments, neurological abnormalities, developmental abnormalities, congenital hypothyroidism, neonatal hyperbilirubinemia, and respiratory distress. So these are the wide range of complications which can occur in the mother, fetus, and also the neonate. So we need to be very careful while managing all these patients. So coming to a study, it's a HADO study in the New England Journal of Medicine, where TSH measured in 25,000 pregnant women, where 62 had mild hypothyroidism, 48 were not on thyroxine. And the mean IQ of children between age and 9, the women with high TSH was 4 points lower than the control. So very sad. So IQ was lesser when compared to the controls. And children and women not on thyroxine, again, the mean IQ was 7 points lower than controls. 15% had IQ 85 or lower versus a control of 5%. So undiagnosed hypothyroidism in pregnant women may be adversely affect the fetuses. Therefore, screening for thyroid deficiency during pregnancy may be warranted. So a lot of outcomes seen in the fetus, in the mother and the fetus also. Anemia, very common in subclinical, and also the overt. Pregnancy-induced hypertension commonly in the overt. Again, gestational diabetes in the overt. IUGR in the overt. And IUD also very high in the overt hypothyroid. And the perinatal outcomes for the delivery and the neonatals, that is the preterm delivery, common, the very high in the subclinical, and also the overt. Cesarean section and fetal distresses again in the overt. Overall cesarean rate in the overt and also seen subclinical hypothyroidism. Apgar score less than 7 in 1 minute in overt and subclinical. Neonatal complications were high in the overt and subclinical hypothyroidism. So these are the things you should understand. So a lot of complications which can occur in the neonate and also during delivery. So how will you manage? As I told you earlier, according to the Indian Thyroid and FOXI guidelines, overt hypothyroidism or overt hypothyroidism with TSH more than 2.5 should be treated. For overt hypothyroidism, levothyroxine dose is 1.6 to 2 microgram per kg per day, and maintain a target TSH levels less than 2.5 above the lower reference range. So patient should not become hyperthyroid. So see the lower range also. In patients with pre-existing hypothyroidism, LT4 is increased by 30% as soon as the pregnancy is diagnosed. One option is to add 2 additional doses per week. That is 9 doses per week, as I told you earlier. In subclinical hypothyroidism pregnancy, okay, LT4 is recommended for in a TSH greater than, it's already into the overt range. And in TPO positive women with a TSH between 4 to 10 milliunits per liter, that is LT4 is recommended here. TPO positive with TSH between 4 and 10. And you need to screen and monitor the patient and target a TSH of less than 2.5. LT4 can be considered in patients with TPO negative with a TSH between 4 and 10, and TPO positive women with TSH between 2.5 and 4. Whatever it is, you initiate treatment, and in the first trimester, target a TSH of less than 2.5. And subclinical hypothyroidism, a lot of data in the guidelines telling that initiating thyroxine in TPO positive women in subclinical hypothyroidism, there is reduced miscarriages and also a lot of complications like you start treatment initially itself in the first trimester itself. There is overall reduction in pregnancy complication rate, and treatment soon after the first prenatal visit found a reduction in the rate of preterm delivery. So subclinical hypothyroidism has also to be monitored very frequently and the target level should be less than 2.5. And here, in women with thyroid autoimmunity who are euthyroid in the early stages of pregnancy are in the risk of developing hypothyroidism, should be monitored with TSH at least once in every trimester, at least up to the second trimester. It's a 1-year recommendation. LT4 therapy can be considered in euthyroid pregnant women TPO antibody positive and with a pregnancy loss. Even though the patient is euthyroid, with the TPO antibody positive, with the previous history of pregnancy loss, consider thyroxine treatment. And in care of women with adequately treated hypothyroidism, no other maternal fetal testing is needed unless in the common test, what we do is fetal ultrasound, antenatal and umbilical cord sampling. And it need not be done in patients with the adequately treated hypothyroidism unless there are other circumstances of pregnancy, like previous any history of any congenital defects or something like that. Then you can go for an antenatal fetal ultrasounds, etc. Otherwise, adequately treated hypothyroidism, there is no need for other maternal or fetal testing. An exception is that in women with Graves' disease, effectively treated with iodine ablation or surgical resection, thyroid TSH receptor antibody monitoring has to be done. This is the algorithm for the hypothyroid patients here. In high-risk group women, check TSH as soon as pregnancy is confirmed. Check TPO antibody if TSH is between 2.5 and 10. So if TSH is between 0.1 and 2.5, no further workup is needed. Between 2.5 and 10, if TPO positive and TSH is in the upper limit of reference range, consider treatment. TSH in the upper limit of reference range 10, treat with thyroxine. Suppose TPO antibody is negative and TSH is in the upper limit of reference range, no treatment is needed. And TSH upper limit of reference range, that is more than 2.5 to 10, consider treatment. Any TSH more than 10, treat with either positive TSH, negative or TPO positive or negative, treat with levothyroxine. It is slightly confusing. I think when you start seeing patients, you will be able to understand. Now, coming to any patient with hypothyroidism, the postpartum, management of hypothyroidism postpartum. So, the treatment is slightly different in pre-existing and a newly diagnosed hypothyroidism pregnancy. In postpartum patients with pre-existing hypothyroidism, post-delivery, you revert the patient back to the pre-pregnant dosage. Pre-existing means you revert, the patient was taking around 50 now in the pregnancy, and the pre-pregnancy she was taking only 25, revert back to the pre-pregnant dosage, and check TSH should be between the after 6 weeks. And some patients in Hashimoto's thyroiditis may require a higher dose than the pre-pregnancy dosage. That you can decide based on the TSH levels. In patients with newly diagnosed hypothyroidism in pregnancy, some women in whom LT4 is initiated during pregnancy or may not require LT4 postpartum. So such candidates for discontinuing LT4, especially when the LT4, that is the thyroxine dose is less than 50, and if you have just started it, it's a newly diagnosed hypothyroidism in pregnancy, you can stop them. If discontinued, TSH should be evaluated in 6 weeks. Women with thyroid autoimmunity, TPO positive, needs annual monitoring with TSH. So this is the management in hypothyroid postpartum. Now coming to hyperthyroidism. Hyperthyroidism is very important for family physicians because these cases can come to you and you need not have any endocrinologist to manage a hypothyroidism. You, as a family physician, all of you can manage hypothyroidism without any problem. That before pregnancy, during pregnancy, or after pregnancy. And why I told this, because the next topic is hyperthyroidism and pregnancy. You need to be a little careful where you need to involve the endocrinologist here. It is 100% you need to involve the endocrinologist, and don't take any risk in managing a hyperthyroid patient. And the follow-up can be done by, definitely done by a family physician, because there are a lot of drugs causing issues. And the diagnostic dilemmas in diagnosing, like differentiating a gestational thyrotoxicosis versus a Graves' disease, a subclinical so and so. So in hyperthyroid, hyperemesis gravidarum also can cause subclinical hyperthyroidism. So the commonest causes are Overt hyperthyroidism can complicate 0.5 to 0.2% of the pregnancies. Graves' disease is most common. Subclinical hyperthyroidism prevalence about 1.7%. It is often associated with increased HCG levels during early pregnancy. And hypergrammosis gravidarum seems to be associated with subclinical hypothyroidism. So according to ATA, when a suppressed serum TSH is detected in the first trimester, that is TSH less than the reference range, take a good medical history, physical examination, and measurement of serum FT4 and TT4 concentration should be performed. And TRIB, thyroid receptor antibody, and maternal T3 also may prove helpful in clarifying the etiology of thyrotoxicosis, because Graves' disease, TRIB and T3 are on the higher side. Okay. The appropriate management of abnormal maternal thyroid test attributed to gestation transient thyrotoxicosis and hyperemesis gravidarum includes, because these don't need treatment, but you need to identify by checking a TRIB and a T3 also. Here the treatment is very simple. Supportive therapy, manage the dehydration. Hospitalization is needed because hyperemesis, the patient may be acetone positive, and there'll be a lot of electrolyte changes and severe dehydration. So that has to be treated immediately. ATDs are not recommended. Beta blockers may be considered, but again, there is a chance of fetal hypothyroidism. Okay. And the thyroid stimulating and this positive is high in Graves' disease in the early pregnancy. If elevated, repeat in 18 to 22 weeks. So what are the effects of Graves' disease? In the first trimester, symptoms of Graves' disease usually could be aggravated due to the increase in HCG production. So it doesn't warrant any treatment. You need to just observe the patient for any like tachycardia or weight loss or something like that. But this all happens in early pregnancy, but you will be slightly confused. And thyrotoxicosis improves in the second and third trimester of pregnancy because of the direction of thyroid, the TSH receptor stimulating antibody levels. So it improves the symptoms of Graves' disease. But postpartum, suddenly Graves' disease comes out. That's due to sudden rise in the TSH receptor stimulating antibodies, and postpartum, mostly after 6 weeks of delivery, the Graves' disease symptoms may suddenly increase. So initially, in the symptoms, Graves in the first trimester could be due to HCG production. You need not increase because antithyroid drugs are very harmful to the fetus. Please don't increase the dose of thyroid drugs. In second trimester, again, the Graves' disease, what is usually the symptoms are very less, and you need not increase the dose, and you can maintain them on the lower dose, which the patient was already taking. Postpartum, you need to be very careful because of the increased rise of TSH receptor antibodies. You need to increase the dose, and you need to identify that also. And what are the complications? Maternal pregnancy-induced hypertension, preeclampsia, preterm delivery, congestive heart failure, thyroid storm, increased or recurrent miscarriage, placenta abruption, infection, increased maternal mortality. In fetus, there's neonatal hyperthyroidism, intrauterine growth retardation, small for gestational age, prematurity, stillbirth, and increased perinatal mortality. So a lot of complications associated with Graves' disease in pregnancy. And according to the guidelines dated 2017, sporadic loss of pregnancy happens in hyperthyroid Graves' disease. Why? It is unclear. It could be due to antibody-mediated mild thyroid hypofunction, cross-reactivity of the thyroid antibodies with HCG receptors in the zone of pellucida, other non-organ specific autoimmunity, increased levels of endometrial cytokines. So why I am telling this? Because if there is a pregnancy loss and the patient is being treated by a family physician, there'll be a lot of comments coming from the gynecological side. So that's why I put this slide. So that's why I told you while treating hyperthyroidism, should be very careful. Any loss in pregnancy will definitely, there'll be a question why endocrinology consultation was not done. So you'll be very careful. So in pregnant women, high risk of developing thyrotoxicosis, continuing antithyroid medication may be necessary. And there are certain factors predicting the clinical risk. That is, who is currently hypothyroid, and a patient is on a treatment of 5 to 10 milligram per day of methimazole, or 100 to 200 milligram per day of PTU to maintain a euthyroid state. And in the early pregnancy, the first trimester, PTU is recommended through 16 weeks of pregnancy. And pregnant women receiving MMI should be switched to PTU as early as possible. And while shifting from MMI, that is methimazole or carbimazole, to PTU, a dose ratio 1:20. Suppose the patient is taking 5 milligram per day, shift to 50 milligram twice. That is around 100 milligram of PTU is needed. So it can be given 50 mg twice daily. If ATD therapy is required after 16 weeks, so because I told you Graves improve in the second trimester and third trimester, and whether to switch back to MMI from PTU, it is still questionable. It's very unclear. Okay, so that's why I told you that has to be decided by the endocrinologist. And in women treated with ATDs in pregnancy, FT4 or TT4 and TSH should be monitored approximately every 4 weeks. For hypothyroid, TSH alone is enough, but for hypothyroid patients, TSH with TT4 or FT4 has to be. Antithyroid medication during pregnancy should be administered the lowest effective dose of MMI or PTU, targeting a maternal serum FT4 or TT4 at the upper limit or moderately above the reference range. And there is a therapy, a combination regimen of LT4 and ATD that should not be done in pregnancy, but in rare situations of fetal hypothyroidism. So, suppose the mother is euthyroid and the fetus is hypothyroid, which is recognized by checking the fetal heart rate more than 160. So, in that conditions, you may have to give a small dose of antithyroid therapy to the mother to control the fetal hypothyroidism. So what happens is the mother becomes hypothyroid. Okay, the mother becomes hypothyroid. So there is a suggestion of a combination regimen that I'll come to later. So drug dosages for PTU in pregnancy Graves' diseases: initial dose 50 to 150 mg, thrice daily, maintenance dose 50 mg twice or thrice a day. In hyperthyroidism other than Graves, 300 to 450 mg per day in 3 divided doses, and 100 to 50 microdose maintenance dose in 3 divided doses. And titrate every 3 to 4 weeks and target FT4 or T4 on upper limit of normal range. In MMI, if you're giving MMI, Graves is 10 to 20 mg once a day, maintenance as per the thyroid function. In hyperthyroid patients, 15 to 40 milligram per day in divided doses and maintenance dose of 5 to 30 mg per day in 3 divided doses. So in maternal hypothyroidism, in subclinical, you do not give any treatment. Okay. So the patient is hyperthyroid or Graves' disease. PTU is recommended in the first trimester according to the guidelines, followed by a switch to methimazole, carbimazole beginning in the second trimester. Choice of antithyroid drug is PTU. And patients on low dose of ATD, in women on a low dose of MMI, that is less than 5 to 10 mg per day, or PTU of less than 100 to 200 milligram per day, just stop ATD in the first trimester. And such patients should be monitored every 1 to 2 weeks. So in the early trimester, due to the high levels of HCG, the mother will be slightly on the thyrotoxic side, hyperthyroid side. So, and after, you need to assess the fetal thyroid status also, as I told you, because that is also important, because even though the mother is euthyroid, the baby can be hyperthyroid. So that you need to assess the fetal thyroid status also, and that is clinically by checking the fetal heart rate. So when is surgery indicated in pregnancy? When ATDs fail to control the hyperthyroid disease, 300 is a patient is requiring 300 milligram of PTU or 40 milligram of methimazole, carbimazole. Second trimester is a safe time suggested for surgery. If patient had iodine treatment for hyperthyroid, contraception is recommended at least 3 months following the iodine treatment. And there is no data for against recommending termination of pregnancy after the inadvertent iodine exposure. So guidelines say that there is no recommendation for termination of pregnancy, but contraception need to be followed at least 3 months following adult. And these are certain studies telling about the birth defects of early pregnancy in antithyroid drugs. So these are the, so if you see this congenital anomalies, definitely you will be a little, I want to tell you, your heart rate will increase. Because if there are, I have seen patients with carbamazole in the first trimester with teratogenic effects. The common things which we see is omphalocele, esophageal atresia, BSDs, and usually the pregnancy, they try to terminate the pregnancy with all these congenital anomalies because the baby is never going to survive. So these are the list of congenital anomalies that can happen in the patient on carbamazole, methimazole. It's called the carbamazole-methimazole embryopathy. So in maternal hyperthyroidism, the mother is euthyroid and the patient is possible for TRAP. That is more than 3 times the upper reference of the assay. There's a possibility of fetal thyrotoxicosis. The fetal heart rate more than 160. In all other causes, if all other causes of fetal tachycardia is ruled out, and if you're sure that it is fetal thyrotoxicosis, then you'll have to start on the mother with methimazole to control the fetal thyrotoxicosis and a thyroxine small dose to maintain maternal euthyroidism in the pregnancy specific range. And monitoring should be done, fetal growth, the liquor content, volume, goiter, etc. And the cord blood has to be tested. The mother on 80, the cord blood has to be tested and check for fetal goiter with ultrasounds for fetal hypo and hyperthyroidism. And the blood test also can be done. Cordocentesis, check the blood for fetal and hypo and hyperthyroidism. So management of postpartum patients of hyperthyroidism, a relapse of Graves' disease, I told you, is seen within 3 months of delivery. Again, TSH and FTF values has to be monitored at 6 weeks and 12 weeks interval. And the total doses of daily doses up to 20 milligram methimazole or for 450 milligram of PTU is safe. And monitoring of breastfed infants is not necessary because as a family physician, this also you should know. Post-delivery, in breastfeeding, what is the safest dose? That is 20 milligram methimazole or 450 milligram of PTUs. Up to 450 milligram is safe. And you need not do any monitoring. And postpartum thyroiditis is a very common entity. It is a destructive thyroiditis induced by autoimmune mechanism within a year of delivery. Usually it is painless thyroiditis. Prevalence is 1 to 17%. Common in patients with previous history of postpartum thyroiditis and a positive TPO antibody titer in patients with type 1 DM. And usually a non-specific symptoms within 3 months of delivery. There's a transient hyperthyroid period and then followed by a hypothyroid phase. Here in postpartum thyroiditis, FT4 is more than FT3 and the thyroid traps are not elevated because you need to differentiate it from the Graves' disease. In Graves, present 6 months after delivery, usually symptomatic. Free T3 is more than T4, trap is elevated, and there could be other signs like thyroid enlargement and ophthalmopathy. And during the thyrotoxic phase, can be treated with beta blockers. ATDs are not recommended in the thyrotoxic phase of PPTs. Following resolution of the thyroid hyperthyroid phase, the serum TSH should be measured 4 to 8 weeks to screen for the hypothyroid phase, and you need to treat for symptomatic hypothyroidism. And if LT4 is initiated for PPT, discontinuation should be attempted after 12 months. If the patient is not attempting to be pregnant or is attempting a pregnancy or is pregnant. Otherwise, you can stop thyroxine after 1 year. And you should test for TSH annually. And treatment of thyroid antibody positive pregnant women either with thyroxine or iodine to prevent PPT, that is ineffective. So if a patient is thyroid antibody positive and the patient is euthyroid, you cannot prevent any postpartum thyroiditis. So there's no use of giving thyroxine to prevent postpartum thyroiditis. Now coming to thyroid nodules, these are certain entities which you encounter. So pregnancy with the growth of pre-existing thyroid nodules as well as growth of thyroid new nodules is you need to consider. And usually, mostly palpable nodules are benign hyperplastic nodules. However, 5 to 20% are neoplasms. Some could be adenomas and carcinomas. An approach to a patient in a pregnant woman with palpable thyroid nodules similar to that of a non-pregnant woman, which includes check for serum TSH, do an ultrasound assessment of neck and thyroid gland. So, if you see any nodule and if you suspect that the size is increasing, or it is a firm nodule or a hard nodule, it's similar to any non-pregnant lady, you go for a TSH assessment and also ultrasound assessment. So a pregnant woman with a palpable thyroid nodule should be evaluated measuring the TSH and the ultrasound assessment of the neck or thyroid gland, and also an FNAC. Final aspiration is mandatory. If the nodule is malignant and shows a rapid growth, consider surgery in the second trimester. The nodule is benign, no further evaluation is necessary, except in patients with elevated TSH, where levothyroxine is given to normalize the TSH and follow up with the ultrasound of the neck. So LT4 suppression therapy should be initiated to maintain a serum TSH in the range of 0.1 to 0.8 for papillary carcinoma or follicular cancer, less than 2.5 for medullary cancers. The size of the nodule is stable. Repeat biopsy should be performed only after delivery. And post-surgically, patients should be maintained on LT4 therapy, monitoring of TSH and free T4 levels every 6 weeks. Post-surgical whole body scintigraphy, radioactive iodine ablation are contraindicated during pregnancy and lactation. So just for your awareness, okay, just you need to know about this. Even though we are not treating much of these cases, you need to be aware of it. If you find a nodule, whether to test it or not, it is up to you. But you need to test it because this could change to be, you can get, malignancy is also common in pregnancy. Commonly, you can see papillary and follicular cancers are seen in pregnancy. So you need to be careful. You need to assess. FNAC is mandatory if there is an increase in size of the nodule, or if there is a consistency, change in consistency of the nodule. And in patients with ICSI and or if you want to do what to tell in infertility, whether LT4 therapy improves the success of pregnancy following artificial pregnancies, artificial treatment, TPO positive urethra. This is not, there's insufficient evidence, but in TPO positive euthyroid woman undergoing ART may be considered for LT4 because small doses can be given, because these patients usually TPO positive, usually by the second trimester, they can go into a hypothyroid state. So either monitor them or you can start them on a small dose of LT4. And subclinical hypothyroid woman undergoing IVF or ICSI should be treated with L-thyroxine targeting TSH less than 2.5, no doubt about that. And the glucothyroid therapy, steroid therapy is not recommended in antibody positive women. So coming to the, I want to conclude by saying that as family physicians, you can strongly, you need not refer any patient with hypothyroidism. You can definitely treat any, that is pre-pregnancy, pregnancy, postpartum, every stage of hypothyroidism can be managed by a family physician. Only thing is monitoring has to be done according to the guidelines and everything has to be conveyed to your obstetrician. But hyperthyroidism, be very careful. Referral guidelines are there. These are the referral guidelines. All women with hyperthyroidism, patients with history of Graves' disease who are euthyroid or hypothyroid through radioiodine treatment or surgery, and also TRAP positive. Any woman with unstable TFTs, that is hyperthyroid, they're specifically mentioning hyperthyroid with unstable TFTs, TPO antibody positive women. Management is covered in the section 1 subclinical hypothyroidism because these patients do not need any referral. If any advice is required, please discuss it with the consultant endocrinologist. If you are confident enough, you can teach, you can treat. Otherwise, you can just discuss and you can manage. And to inform obstetrician if hyperthyroid patient is diagnosed during pregnancy, all women with hyperthyroid profile postpartum, to assess the postpartum thyroiditis and Graves. You need to differentiate between postpartum thyroiditis and Graves' disease. Any woman with history of hyperthyroidism should also be discussed or referred. All women with hyperthyroidism in pregnancy should be seen by a consultant endocrinologist and a concerned obstetrician from early in pregnancy, because there are a lot of issues. Even in our hospital, we had a problem. The patient, the pregnant lady was taking, she was working in our hospital. She's a technician, anesthesia technician. I'm so sorry to say that the patient was on methimazole, carbimazole, and she was continuing it in the first trimester. And the second trimester, there was a lot of congenital anomalies seen, and it was not identified by the obstetrician. So imagine the problems that happened. That does not refer to the physician also. So you need to be very careful. Every family physician need to be aware. History is very important. Whether this patient was on small dose of anti-thyroid drugs, everything. A short history has to be taken regarding the ingestion of any drugs, and see if the patient is on ATDs. Kindly refer the patient to the endocrinologist. You can just stop the ATDs for no, you can, because it's a small dose, you definitely can stop it and refer the patient to the endocrinologist, and then you can follow. There's no problem in following up the patient. But otherwise, refer the patient. These are my references: ATA guidelines, the FOXC, the Medical Disorders and Pregnancy Committee, and the National Guidelines for Screening for Hypothyroidism in Pregnancy. Thank you.
Thank you, ma'am, for that elaborate session covering all aspects of thyroid disorders in pregnancy. Now the session is open for discussion.
It's a very wide topic. I know that, but I actually presented this topic in the 2024, 24?
23.
23, yeah,
23.
I was telling this to Vishnu, there were only 15 attendees in that. So I wanted to share this to everybody. So today there are more attendees, because I work as a family physician. I work as a critical care consultant also, and as well as a family physician in a hospital where there is, it's a purely obstetric and gynecology hospital. So I get a lot of patients like this. So a lot of dilemmas come. That's why every time I go through this topic, because you need to be updated. And hyperthyroid, it's really scary. You can treat, but I told you, there is a pregnancy loss or something like that. There is some congenital issues which happen, and you'll be sued for that. So 100% you need to refer any hyperthyroid pregnant patient to the endocrinologist and just follow. Hyperthyroid you can manage, no problem. If you have any doubts, you can always consult with an endocrinologist and follow up the patient. Never feel that you will be losing a patient. They will come back to you, definitely. They will definitely come back to you.
Ma'am, there are some questions in the chat. How to add the dose per week, how to increment? Can you please explain?
Yeah.
How to
increment of dose? They told you just add 2 doses as soon as the patient is pregnant. As soon as the patient is pregnant, add just 2. If the patient is taking 25, you can add 2 more doses. This is 50 microgram per week. Then you monitor the TSH levels. Okay, TSH levels, and you can slowly, and if you reach the target of less than 2.5, you don't increase the dose at all. Only avert, they have told you, just start on 1.6 to 2 microgram per kg. Initiate, that is around 100 microgram per day. Then after 4 weeks, you see the whether the TSH levels has come to the normal levels. Usually 99% you will be able to reach to the trimester specific range. Then gradually you can increase 25 increments per week. You can increase not per week, till up to the next 4 weeks you can give another 25 micrograms, and then you can again check the TSH. Okay, you understood? For any overt hypothyroidism, the starting dose is 1.6 to 2 microgram per kg. That is around 100 microgram. Then after 4 weeks, check the TSH. 99% it will come to the trimester specific range. If not, you add on another 25 for the next 2 weeks. If it comes to, that is, if still not has severe hypothyroid like 100 micrograms and all, usually it is, see, that is it's very unstable patient. So that patient will definitely go for any, what to tell, pregnancy loss. If a TSH of such, what to tell, such a high TSH and all will go for a pregnancy loss and all. So that in that cases and all, you'll have to see the, what to tell, you can consult with the gynecologist, obstetrician, and think about whether continuing the pregnancy also, because that will be, you need to monitor the pregnancy, what it will by ultrasound also. And in that cases, you can consult with the endocrinologist and decide what to do in this pregnancy, because such a morbid, that is severe hypothyroidism, pregnancy is quite dangerous, like a TSH at the level of, what to tell, 100 and all. But nowadays, it's very rare to get a level of such high levels of TSH. But avoid, that's anything about 10, start 1.6 to 2 microgram per kg, that is 100. And after 4 weeks, check the TSH. And if it's not reached that level, increase by 25 microgram. Again, monitor after 4 weeks. That is what we advise. But very high levels of TSH, always consult with an endocrinologist, like 100. If you see 100 TSH in a first trimester pregnancy, it is very dangerous, because there is a chance of pregnancy loss or congenital problems that can occur. Okay.
And there is
Dr. Indu,
another
I have a
question.
question for you.
Yeah.
Dr. Indu?
Yes.
See, in a first pregnancy and first trimester, TSH will be somewhere around 2.5 to 3.
Yeah.
We are studying the patient on 12.5 mg or whatever as you suggested, based on the body weight, we started. And throughout pregnancy, they maintain the same dosage.
Yeah.
And I'm seeing many of the gynecologists after delivery, they stop it without cross-checking.
Yeah,
So do you recommend to cross-check it after the delivery?
Yeah,
After
because
3
I
or 6
follow the
weeks?
patient after pregnancy. I told you where I work. I follow them. I tell them to come after 6 weeks. I told you, the patient thyroxine is started during pregnancy, and if the dose is less than 50 microgram, you can stop the thyroxine and check the TSH after 6 weeks. And you can decide whether it can be restarted or not. If the patient was taking, patient has got a pre-existing hypothyroidism, like already taking thyroxine, and you have increased the dose of thyroxine in the pregnancy, like from 50 to 100, you can go back to the pre-pregnant dosage and again monitor after 6 weeks of pregnancy and decide on the dosage. Okay. Understood?
Okay.
You should not just leave the patient after any patient on thyroxine, after 6 weeks, check the TSH. Okay.
No, thyroid, iodine is the only mineral which is based on the diet of the mother.
Yeah.
So during pregnancy, mother is replacing with whatever the medication we are giving.
Yeah.
But as soon as the delivery over, baby is on exclusive breastfeeds.
Yeah.
And we are stopping the treatment for the mother because we consider it is a normal because the dose is very less. So after the delivery, the baby is not getting adequate amount of iodine because mother is not supplemented now. So how the baby will have a good source of iodine?
That we'll have to ask.
If the baby is exclusively breastfed.
Exclusively breastfed. I don't
because
know.
Iodine is the only mineral.
Yeah.
Yes. So how to consider that?
Breastfed child. I don't know. Is there any pediatrician here? I don't look into the baby side. So I think anybody has got the answer for that?
No, I was just reading an article on supplement.
Yeah. I understand that.
So in that article, I read this.
What was the answer in that?
No. Even I have a doubt because it's only the supplementation they are mentioning.
Yeah. Okay.
So I saw this and I thought of let me ask you this.
Even in post pregnancy, they recommend around 150 milligram of iodine or something like that for the breastfeeding mother also. During pregnancy, the requirement is around 220 to 290. Okay.
Yes.
Yeah. Post pregnancy.
Because in our customs, even though repeatedly we are telling to modify the diet and increase the quantum and quality of diet, because all the grandmothers doesn't follow our advice.
Because usually
So
our
then,
foods, iodized salt, universal iodization is already there. I think iodine deficiency, I don't know, even
no, it is
your
there,
part
but
of your...
at home, they doesn't give that.
Okay.
The
They don't
non-salt,
give salt?
non-spicy. No, no, it's very less.
Yeah, okay.
Even now.
Because iodized
Whatever they
salt, iodized salt has just created a big difference, right? Very big difference. And I think most of the foods like dairy products, breads, eggs, everything has got iodine. So I don't know. In our part of Kerala, I don't think that's a problem. But from your state, I think you'll have to tell me the issues regarding the nutrition of the mother postpartum, whether they're getting all this supplement and everything.
Okay. Thanks for
Yeah.
elaborative talk, ma'am.
Thank you.
Ma'am, two questions. First thing is, what is the maximum dose of thyroxine in pregnancy? And second question, if a pregnant woman is using 100 microgram, that is high dose, how to stop such a high dose after delivery?
Yeah. I think second part of the question I have answered, right? Because second part of the question is if the patient has got a pre-existing hypothyroidism, and if you have increased the dose to 100 microgram in pregnancy, you revert back to the pre-pregnant dosage and check the TSH after 6 weeks. And if the patient is thyroid antibody positive, that TPO positive, you may continue on the same dose of thyroxine and you can monitor, because thyroid antibody positive patients can again need more amount of thyroxine. So in those patients, you can continue, but still you can reduce the dose from the 100. Maybe you can come to 75 and monitor after 6 weeks. First question, what was the question? High dose, any dose, that is because
what is the maximum dose?
Maximum dose, yeah, maximum dose. I think 300 can be given. 300, because there are patients with thyroid carcinomas and all on suppressive therapy with thyroxine who get pregnant. They are on 300 microgram of total thyroxine. So I think that's the maximum dose I have seen, 250 to 300. I have seen. Patients severe, that is post-thyroidectomy patients. So thyroxine usually doesn't cause any problem to the only thing is we need to target the trimester specific range. And I told you, patient with follicular cancer, the TSH level should be on the lower side. I will just slide and show you.
And there is a question about THYRATs. Can you tell something about the THYRATs? That is
surgical. Surgical, I don't know.
Yes.
Usually, I don't advise anything. That is, I think, from the side of the family physician. I don't think. The ultrasound findings, no?
Yes, ma'am.
Yeah. Usually, I told you, I usually refer all those patients to the surgeon. Only the basic investigations you do. What you do is check your TSH, do an ultrasound, take a FNAC. That's it. That is, as a family physician, you can do that much.
Good evening, ma'am.
Yeah.
I am Dr. Mahesh, ma'am. I'm family. I just asked that question about THYRAT score. So that's what, ma'am. It is an ultrasound scoring system.
Yeah, I know.
If it is more than some 3 or that, compulsory we have to do an FNAC. It's I don't have clarity on that. That's why I asked, ma'am. Okay, ma'am.
Even I don't have clarity on that. Usually I refer those patients because I don't prefer to keep them.
Yes, ma'am.
Yeah. If you have facilities, you just send them off.
Yes,
ma'am. In pregnancy.
Yes, ma'am.
Yeah.
Thank you so much, ma'am. It was a good class, ma'am. Yes.
Thank you.
There is another question, ma'am. If a couple is planning pregnancy, husband and wife both diagnosed with subclinical hypothyroidism, is there any recommendation for starting treatment for the subfertile couple, male partner?
Male partner, right? I don't know, because actually female partner, okay, 100% we'll have to, if it's a TPO positive, you need to treat. Male partner, subclinical hypothyroidism and infertility, I don't know. Actually, I have to read about that. I don't have much idea on that. But overt, anyhow, we'll have to treat. Subclinical, I think I have to go through. Again, we'll have to check whether thyroid antibody positive. but whether it will affect the infertility, whether the sperm count or something like that, I have no idea. But overt, anyhow, we'll have to treat. Subclinical, male partner, I have to read out. I don't know. Thank you. Anyhow, I got a question. I will have to refer that and say. Female, obviously, we'll have to treat.
Is there any difference between thyroxine and levothyroxine?
Yeah, levothyroxine is that what is available is levothyroxine. No? The tablet what is available, T4, what is available is levothyroxine.
Yes.
Anything else?
There's one more question, ma'am. Can we add the weekly increments to non-pregnant thyroid patients?
Pardon? Increment? I didn't
Can we add the increment doses, weekly increment to non-pregnant hypothyroid patients?
Non-pregnant, you don't have much. You see, non-pregnant patients, the targets are slightly, it's not, you don't have the trimester specific and all. No? You can increase, the targets, you can, depending on the targets, you can increase, no problem. If it's overt, anyhow, you'll have to treat. And there also, I think the dosage, the initial starting dosage is slightly on the lower side, 1.2. Here it's 1.6, right? 1.2. And the targets could be up to 2.5 to 4 is acceptable. And slowly you can increase it. You see, depending on your monitoring, you can either extend it to 6 weeks or in pregnancy, it is 4 weeks. I think in non-pregnant, you can extend up to 6 weeks and you can see you have reached the target. There is nothing specifically told about the increment in increasing that, because in pregnancy, you have very less time, no? Before the fetal brain, fetal thyroid develops, it takes around 12 weeks. So you need to increase it very fast. So in pre-pregnancy, I actually don't know, probably 6 weeks. Actually, when I start somebody on that, I check them after 6 weeks. And guidelines, you'll have to check at what level, how many weeks after starting you need to check. Usually 6 weeks, I think the first, after you start, after 6 weeks, the first test can be done after 6 weeks of starting the thyroxine. Then gradually, if you reach the specific levels, you just monitor them every 3 months. Then annually you can check. I think in pre-pregnant or non-pregnant patients is like that. 3 to 6 months, then annually. Only in pregnancy, you monitor every 4 weeks. Usually what I do is, in non-pregnant ladies, I start thyroxine. After 6 weeks, just check. Then within 3 to 6 months, give another check. Then annually. If the patient wants to become pregnant, then the routine changes. And I think I'm clear.
There is one comment, ma'am, that is thyroxine and levothyroxine both are available. What
Both
is preferred in pregnancy?
What is available is our levothyroxine. What is available, our thyroid drug is levothyroxine, no? T4.
Yes.
Yeah. I don't think there is a different given for pregnancy and non-pregnancy. The only thing which is available, T4, is levothyroxine. Anything else?
Actually, the person who have shared Tyrono, I understand, is actually levothyroxine itself. Even though it's written that, so it's having levothyroxine as the active component is So
That's
I think we are using, preferably in clinical practice, we are using levothyroxine. So I think we have answered almost all the questions. Thank you, ma'am, for this elaborate session on a very important topic in clinical practice. In fact, we had around 96 to 98 participants for the session. and I hope it was very informative to everyone who have joined.
Yeah.
Thank you,
Yeah,
everyone.
2 questions I have to refer, and preferably I'll tell the answer. One is subclinical hypothyroid in males, right? Whether
Yes, ma'am.
yeah, that I need to refer. And one more thing is about iodine requirement in postpartum. Yeah, that was one question. Postpartum, what advice you will give, no? Because okay.
Yes.
That thing I need to refer that.
So thank you, everyone. We'll hope to see you
Yeah.
with some other session. Thank you.
Okay. Thank you.